Let us know when you're ready.
Okay. Hi, this is Heather Haynie, and I am a RN BSN student, and I am going over with some of my coworkers who are nurses and healthcare workers about the presentation I'm about to give today. And this has to do with dialysis patients and the importance of anemia management in dialysis patients. One of the biggest things that we want to do, my presentation is about trying to implement adding vitamin B12. And in the handout that you have, you can take a look at it, and also I have it here on the monitor. This has to do with the importance of anemia management in patients that are end-stage renal disease. Why adding vitamin B12 will assist with reducing the anemia issue that is common amongst the patients that we have. Now, in most instances, do you all notice sometimes our patients come in a little tired, sometimes have like a slow gait? They're always complaining about being somewhat, lethargic. Do they come in sucking on ice chips most of the time? You see, there may be one or two of them that are even more tired than the rest of them. What we would like to see happen is having to add a supplement to their treatment plan to help them overcome the anemia that is associated with dialysis. And years of research, if you take a look at your handout and also to the monitor here, you take the years of research has been out there to eliminate the anemia problem that is associated with dialysis. Some drugs that are on the market right now, Epogen is one of the gold standard that's used right now, and that is been out for a while. But what about adding a little bit of vitamin B12? Vitamin B12, in the research that has shown, is the one that can actually provide a lot more energy, provide a little more energy for the patients. What is anemia? Let's understand what is anemia. Anemia is when you don't have enough oxygen carrying pigmentation in your blood to help with to increase your energy level. The acceptable standard for an adult male is between 14 and 16 grams per 100 milliliters. For women, it is 12 to 16 grams per 100 milliliters. When it falls outside of those parameters, normally the patient is classified as being anemic. Types of anemia, there are several types. You have iron deficiency anemia, where you don't have enough iron stores. You have folic acid anemia, where you don't have enough folic acid in your diet to help with the oxygen carrying capability that the body has. And you have pernicious anemia, which has to do with the intrinsic factor that is in the stomach that helps to convert vitamin B12 to vitamin B12 help to convert vitamin B12. You have aplastic anemia, which is more or less when you have a bone marrow issue, and this is very common among cancer patients. You'll have also you have renal associated anemia. If you go to this is most likely, this is also on page 3. Take a look at page 3. You have the renal associated. This is where you have our population of patients, which is our kidney patients. They're the ones that will have anemia. What happens is they will have shortness of breath. They usually have fissures or corners of their mouth that has like cracks and such like that. Those are signs and symptoms of anemia. You also have heart palpitations, which is why anemia is such a serious problem. This discussion is about the management of anemia among the dialysis patients. Now, if you take a look at your handout, you'll see the hemodialysis, which is what we do here in our center. You can show in our center here we have we do hemodialysis, and you can see here the different types. You have the catheter. You have the catheter, that is one of the access that's used. And you will also have a graft or fistula. In the catheter, that is a tunneled into the subclavian. You can have that one is tunneled into the chest or into the neck and the jugular vein. And you have the graft or fistula, which is in the arm. It could be in the lower arm, the upper arm. And those are created. The fistula is a person's own veins and arteries that are actually attached. A graft is like a soft, pliable membrane that the vascular surgeon attaches, and that would be the one that they will use to create an access for the patient. End-stage renal disease patients, take a look here. You have the kidneys. You have a healthy kidney, and a healthy kidney does wonders for the body. It actually plays a pivotal role in filtering the body and also maintaining electrolytes. It is also known as, it's also an endocrine gland in the fact that it also it releases a hormone called erythropoietin. And erythropoietin is what stimulates the bone marrow to make red blood cells. In the end-stage renal disease patient, they do not make erythropoietin simply because that function of the kidney is reduced, is eliminated. The epogen or erythropoietin stimulating agent is a mixture. It's actually created to use as part of the treatment plan, and that is what we add to the patient's medication mix to give them the advantage that they need. If you take a look here, the epogen alpha is like the human, it's like a human generated one that is used. And it's used for mostly cancer patients and renal patients. Sources of vitamin B12. Sources of vitamin B12, you could see some facts about it is that vitamin B12 is water soluble, it's non-toxic. It also has, you can actually get this particular vitamin in some of your foods that a lot of people like salmon, king crab legs, liver, blue cheese, clams, and oysters, and of course eggs and poultry, which a lot of people consume. The king crabs, you have to be careful with our patients because it has a lot of purines in it. And while the fact that it has a lot of purines in it, renal patients may have a problem getting rid of some of the purines because their kidneys don't function very well. Why have this changed? It's because anemia is an important, a big problem among our patients. And trying to get this added to their protocol will actually help to reduce the need for the epogen, because one of the problems that research has shown is that epogen can promote problems in cancer patients if they get too much of it, and that is, it promotes tumor growth. And the fact that if we can actually add vitamin B12, we can actually go ahead and reduce the need for the epogen. It also helps when a patient is also slow to respond to the epogen. You don't want to keep increasing the dose, giving them larger and larger amount of that. And here are some more facts about it. A lot of the patients that we have, they are have other problems as well. They have complications from diabetes, hypertension, other things that go along with the reason why they're in this situation. And also for the older population of renal patients, a lot of different medications are very confusing. So what I would like to see is that in our protocol, when we try to give the patient vitamin B12, we will actually go ahead and either the ones that are more anemic, we would actually give them IV. With the ones who are not as anemic, we would give them like oral, give it to them as an oral supplement. Okay, this here is a question. Will vitamin B12 reduce the requirement for the ESA requirement that would lead to better patient outcome? And we're looking at about 6 months of trying to do this. And we would like to see results in about 6 months. These are the research that's been out there, and they have been done in Europe. Some have been done here in the United States to show that the addition of vitamin B12 will dramatically reduce the need for the epogen, and also reduce the anemia problem. Vitamin B12 is like an enzyme that is in the stomach that helps to convert that to a usable something that can assist with helping to reduce the anemia problem. Okay, the patients that we have, we cannot really give them the high flux dialyzer. We will definitely need to use a dialyzer that is not a high flux, that will have too much clearance on the vitamin, because it's water soluble. It will leave the body, and it's also it's non-toxic. There has been research to show that at least 300 to 3,000 times the amount recommended allowance has been given, and has been no side effects for those patients. The ESA dose, which is the epogen that is used as a supplement, has reduced the amount from 11,000 units down to at least 5,000 units per week. So that is one of the research that shows that giving vitamin B12 would be very good. Other research has shown that giving them intramuscular injection has not created any dramatic issues, and it also caused the epogen requirement to be reduced. What I would like to do is to have some of the nephrologists and some of the healthcare teams to collaborate to actually make this one of the protocols that we have for our patients out there. And it actually will help to keep them out of the hospital, because as you know, anemia creates cardiac issues. Other research you hear, if the patient is an abuser of alcohol, you really do not want to give that to them, because they're really destroying the intrinsic factor in the stomach that would help to convert the epogen, the vitamin B12 to be usable by the bone marrow. And you would also have vitamin C, which is already, there's some stores in the body. The vitamin C will help to convert B12. Now, you don't want to give them additional vitamin C, because they're not going to, it will actually create kidney stones for them. So you don't want to give them that. But a patient that is actually an abuser of alcohol, you don't want them to do that, because you have cirrhosis of the liver, and elevated liver enzymes would be one of the biggest problems. And you don't want to have that. Now, the expectation that I would like to see is to have this reduced eliminate the anemia problem amongst our patients, give them a better chance of living a more healthier life, and get all the healthcare providers involved, dietitians, nurses, nephrologists, and primary care providers to kind of get on board with it. And of course, you know, anemia is a problem. We have a lot more patients are having renal disease and wind up being transferred to dialysis. So what we're trying to do now would be to manage this population of patients as much as we can to get them in a better position, and try to address the root causes of this, and eliminating the complications of anemia, and having vitamin B12, which would be the secret to accomplishing this goal. All right. Does anybody have any questions?
So is this research built on the fact of dialysis patients, or is this just typical group?
No, this is built on dialysis patients.
They have tried it on
dialysis patients. Some of the research has been done, like I said, in Europe, Australia, Asia, and in the United States. So
what are you're suggesting there? They use B12 to complement estrogen, not to get rid of the estrogen, just
not to get rid of it, but to complement it, so you don't have to use as much estrogen to really accomplish the anemia problem. Because I have heard some of the patients say that, oh, I went to my doctor and they gave me an injection of B12 and I had the best energy level there is. And basically, if we were to go ahead and add this as a protocol, I believe that this would be one way of managing.
Okay, so the estrogen is gonna help build red blood cells, which is gonna give them more oxygen.
Oxygen capability.
And that's gonna help with the energy level. And the B12 is not building red blood cells. It's just helping with what part of the
It will actually, the B12 will actually be the one that will help with the oxygen carrying ability of the hemoglobin.
Okay. So that means that. See, I'm trying to figure out now, when they have issues like hospitalizations, you know,
well, with the
hospitalizations, the estrogen level, you know, the hemoglobin drops a lot.
And this is one way of keeping them out of the hospital. That's my goal, is that if we were to implement this, this would actually help to keep them out of the hospital, so that they will continue to have at least as healthy a life as possible. Because when they're in the hospital, yes, the hospital is going to look at whatever caused them to get there.
Right.
And if it's something that has to do with one of their comorbidities, while they're there, they're going to be dialyzed, and they're not going to have the supplements that we have implemented here to that we give to our chronic patients.
Yeah, this is just the dialysis patients are so sensitive to everything. That's what I'm trying to say. And what about this is going to be given oral? IV?
You have the IV ones would be, I would see the IV ones for the most anemic of patients, the ones who we can't get their hemoglobin level above 10.
So how does the IV iron work with that? Because that's supposed to be the supplement. That right now
it's just
the IV iron, you want to help with the stores, but it also helps, you know.
It also helps, but
especially when their hemoglobins are low. So, you know.
But some people are so hypo-responsive that when you're thinking about having them getting the extra vitamin, which is pretty much like somewhat like a natural substance. You know, most people take vitamins. We're just talking about taking a little bit more of the B12, because the B12 is water soluble, and so there's no risk of toxicity in that regard.
Well, what about dialyzing? What about, since it's water soluble?
You don't want to use a high flux.
Well, that's what I'm saying. That's what we do high flux.
It's not going to dialyze out of the.
Sometimes it will dialyze out.
That's what I'm saying. But we do high flux. I mean, that doesn't change. High flux is all we do. If we don't do high flux, then You know, the reason we do high flux is in order to shorten the dialysis time. If we don't do high flux, then they would have, you know, 4 hours is 8 hours. That's the reason we came with them. That's why we do high flux, because we had, in order to shorten the time, the treatment time. So if you don't do high flux, you would have to increase the, you know, the treatment time in order not to be able to absorb, you know what I mean, to clear out the B12 out of the system. Because if it's water,
well, if
water
we're gonna
soluble,
be giving it, we're gonna give it to them, and even if we can get to the point where we can actually get at least some of the hemoglobin level to at least.
or is it more, or is it better for patients like with peritoneal, where they're just using their belly instead of using the high flux?
Well, I'm sure there's some research out there on those. I didn't get into that research.
Yeah, because I'm trying to see, you know, because either a nocturnal patient, you have nocturnal patients that run longer.
Right.
So
Yeah,
they
that
will
might
be
be
better,
better
for them. But when you're doing hemo during the day, it's all high flux. Even at night, it's high flux. But at that instance, it don't have to be high flux. You see what I'm saying? So you probably would be, you know. I mean,
like
I'm trying to see
even
which
if we
group
increase, even if we were to use large amounts of B12, and some of it, you know, I would think that it would at least help in some, at least in the long run.
So what about cost?
The cost?
Epogen is very expensive. So if you're talking about supplementing with B12, what is the cost?
Well, you're not going to be using as much Epogen, so it should balance out.
I understand what she's coming
See,
from.
B12 helps with the energy, and it comes, and now a lot of people are using it, you know, like efferent. You drop it in the water and it just dissolves. They make it like dissolving, so you can drink it straight. And then but for dialysis patients, you know, because they come to dialysis, I think it would be best, like, for those that will be using IV, it would be best, like, we give antibiotic towards the end of the treatment.
Right,
it would be best towards the end of the treatment. And for those that are high risk, and for those that are not high risk, that can take it at home, and the doctor can prescribe it like it's like juice,
like a soluble,
like a soluble. They just drop it. And I use
work.
it. I mean, in England, it's something you go to the store and just pick up.
Of course, in England. In the foreign
And
countries, you can go and get everything, just
easy.
right to the
And
store.
And that's a very good point too. That giving it towards the end of the treatment.
End of the treatment is the most important one.
Really,
because
helps with energy level, and it's cheap. Like you said, water soluble. The amount your body needs is what you use. Once you don't need, you pay it out. But because, you know, dialysis cannot do that. But then you just, like you said, Epogen is expensive. And Epogen and now some of the patients, you can't give Epogen to them, especially patients that have cancer.
Cancer patients.
Some cancer, the Epogen, they find out that there's some cancer you cannot.
The tumors grow.
It helps the tumors grow.
It's against the so for those patients, maybe vitamin B12
would be the
best
drug of choice.
Yeah, for those for the cancer patients, right?
No.
It will be best
Sounds good.
because it will give them energy.
It does.
And it will,
like you said, towards the end of the treatment, that's when they should be giving it. Because if they give it early, then it's going to dialyze.
Right.
It's going to dialyze out.
I see what you're saying.
Very good.
That's good.
Okay.
that's informative.
Well, thank you. Thank you so much for spending part of your long work day to hear me out on this. I do believe, I do believe that this could actually work for our population of patients that we have, our renal patients. And of course, most of our patients, they're pretty stable, but they have some that become unstable, especially our older population that has been on dialysis for in excess of 15 years or so.
Maybe
and of course,
young people too.
and then some of the young people. And I think more or less that this would actually be one of the things that would be protocol. So I thank you. I have in the handout there's some references if you want to see where I got some of the information from. Then it's all right there.
Okay.
All right. Thank you.
Very good.
Thank you.
Very good.
That's good.
For a second.
Good.